At the back, close the doors so that we have good quality sound in here. Well, thank you to the fourth of our major policy sessions. This is on reforming Australia's mental health system. It is my pleasure to introduce Dr. Sebastian Rosenberg, mental health policy academic and consultant, who will chair this afternoon's session. I've been specifically denied by Sebastian the right to read out a very long CV, and he tells me he'll introduce himself. So, Sebastian, thank you.
Thanks. Thanks very much, Beverly, and welcome delegates to this session about how to reform mental health in Australia. So I'm hoping we'll get an early mark because it should be a fairly easy topic for us to conclude. I'd like to start by acknowledging the traditional owners of the land we're meeting on today and pay my respects to the elders past and present. Sebastian Rosenberg's my name. I work at the Brain and Mind Centre at the University of Sydney. I also work at the Centre for Mental Health Research at the Australian National University. Just briefly how this session will operate. We have, I'll do a quick set of introductory remarks which to my mind at least help to set a context for our discussion today, which I hope you'll find helpful, useful. Then we have four terrific speakers. We have Tony Bartoni, Ian Hickey, Margaret Kay and David Mountain, and I'll let them introduce themselves very briefly as they speak. They'll have about 5 minutes each. Then I'm really going to open it up to you to ask questions and to have a discussion with our panel and with each other. I might also take the opportunity at the start of asking Vinay Lakra to make a few comments as well, President-elect of the RANZCP, who's here with us this afternoon. So that's the way the session will work. So by way of introductory comments, there have only been 2 surveys of national mental health and wellbeing run by the Australian Bureau of Statistics. One was in 1997 and one was in 2007. In the 1997 version, it showed that about 38% of people were receiving, 38% of people who needed mental health care received mental health care. And a decade later, that figure was 35%. We're now paying $14 million a week to psychologists, and apparently that number is now 46%. The percentage of people who are being treated by our state and territory mental health services was about 1.8% of the population in 1992-93, and in 2016-17 that figure was unchanged. In 1992-93, when we first started with our first national mental health strategy, the mental health represented about 7% of the health budget, and in 2016-17 that figure was unchanged. There, I guess, is a sense I get when I talk to clinicians and talk to health professionals and service providers, and indeed to the community, that many things have changed in mental health, but I'm not sure how true that is. Certainly the asylums were closed in the 80s and 90s, although it is worth noting that there are about 1,000 beds still in psychiatric specialist hospitals across Australia, which take up about $500 million of expenditure. So many people would say that in fact what happened was we failed to invest in the community mental health services that were promised at the time the psychiatric institutions were closed. So in fact, in my mind, and again this is shorthand and I'd be interested in the comments of the panel and indeed your comments, I see in some respects separate streams of mental health have evolved. There is now a federally funded primary mental health care stream. There is a stream of funding for services in mental health provided through the states and territories, principally through hospital-based care, inpatients and outpatient care. And lately there is also more money that has come to the system for a particular clientele through the National Disability Insurance Scheme. So in some respects you sort of have 3 parallel service structures which have emerged, which I think indicate in some respects that what matters is not necessarily what works in mental health, of which there's increasing evidence, but who pays. And I think that these three separate streams don't touch each other. And on that basis, it makes it very difficult to assert philosophies like stepped care or integrated care or other types of care that people here may be interested in. So that's my very broad brush, generalised way of starting the conversation and setting a broad context. And so with that, I'd like to invite Tony Bartoni to make our first presentation. Thank you.
So thank you for that introduction, Stephen. Seb, sorry. Now, so I'm here wearing my GP hat today rather than my AMA hat. But first of all, let me just quickly frame the discussion from which the point I'm coming from, and that is the advocacy and the lack of coordination and I suppose funding across the various state and federal divides and having a clear process or a pathway in terms of how do we access mental health care. And it's that word access which has been fundamental in my time here at the AMA. So let me now put my GP hat back on and give you a little vignette to illustrate exactly that point. About 18 months ago, I had to certify a patient. It wasn't at all how I imagined it would be. The patient was a patient who was on Suboxone and was clearly come to the surgery after previous episodes where she required to have inpatient stay. She'd come in a very agitated and anxious state, and was clear that she was taking ecstasy as well as a whole heap of other medications. She indicated that she was going to drive home. She was obviously in no fit state to drive home, and so we tried to convince her to stay. Between the practice nurse and myself, that took the next couple of hours of trying to access the CAT team, which in the end were thoroughly useless and didn't, because of her lack of cooperation, wouldn't come out. The ambulance to come out and take her to an emergency department because she needed acute care. Wouldn't take her away without her cooperation, so called the police, and then they wouldn't do anything unless I sectioned her. So that whole process, as I say, took several hours, became very, very tense, very, very confrontational, and really was not what the practice was appropriately resourced or prepared to actually take out. It was a very a whole confrontation that then required some debriefing inside our own surgery in terms of the outcomes of that. Let me give you another quick vignette. A young adolescent girl who was an inpatient for anorexia last year, and clearly also having being in association with some clear signs of psychosis, and she's on some medication including olanzapine and lorazepam. She clearly decompensated over the recent months, and trying to access care for her in a private setting took the best part of 6 weeks. Now, I'm sure you all know that my practice is, well, used to be 10 minutes from the CBD. It's probably 15 minutes now with infrastructure congestion, but it's within spitting distance of 3 teaching hospitals. And I couldn't get her in to either publicly funded or outpatient care, couldn't get a private psychiatric appointment for her. Clearly she was to the point where she was now not attending school and not able to continue her normal lifestyle outside of the family home. So they're 2 little vignettes, very summarised very quickly, to illustrate the whole point of access, and that illustrates there is absolutely nothing in the general practice setting that allows a GP whose day is predominantly a raft of various presentations to access supported step-up care before the problem becomes too acute. Or similarly, if the problem has become acute and they do come out from inpatient care, there is nothing to help you manage the step down in the community. They don't, of course, as people would thoroughly appreciate, that transition from acute to supported community care is not a gradual transition. It can be episodic, there can be fluctuations, and you need to have the access or the opportunities to consult, to seek input and further direction in how to keep that patient from representing again. And back to the first example, this person had already been through the stages of multiple presentations. So the lack of support, the lack of coordinated programs, both in the public and in the private setting, to assist GPs in their daily care of the multiple patients who do come in with some form of mental health presentation. Now, not all patients who require mental health care in general practice are obviously so acute. We deal with the range of presentations. There is everything from mild anxiety, depression, right through. But the other thing that's lost in the process is that these patients aren't just presenting with mental health conditions. There's about a 40 to 45, 50% overlap, depending on your patient profile, where they have obviously complex and chronic disease as well. So the comorbidity factors are a significant part of this presentation. And often you can't manage the other part of the conditions without obviously managing their mental health and well-being in the first place. So those factors, set the backdrop for what is obviously a difficult set of consultation factors. But then it comes back to the question of time. And we all know that in general practice, we're not appropriately funded, even for the work we do in a standard consultation, but let alone something that's as complex and as detailed as that. Now,
we'll get to that, Tony. But look, thank you. I realise this is difficult to do in 5 minutes, but there'll be more time for discussion, I promise. Ian, would you like to just quickly introduce yourself?
Yeah, I'm Ian Hickey. I'm a psychiatrist and the co-director of the Brain and Mind Centre at the University of Sydney for Health and Policy. The role that I've had most importantly over the last 6 years, between 2012 and 2018, was actually as one of Australia's National Mental Health Commissioners. And that was set up by Julia Gillard at the time because federal governments and state governments over a long period have actually had national mental health policies. There have been increasing investments in the area. But she said basically, we don't know whether the money we put in actually makes people's lives any better. We've got to look at the sort of accountability and the fundamental structure of the system. And so that commission was set up with that particular purpose. Now, it did produce a report for government in 2014 about the shape of actual national mental health services. Basically said it doesn't work. Now, the structure is fundamentally wrong. It's not patient-centric. It doesn't deliver in place. It's a series of disconnected investments by all sorts of levels of government that are not organised around the person, their family, their needs, and the place in which they live in a sensible way. Interestingly, that sat on the Department of Health in Woden, that report, for a year, and nothing happened when somebody leaked it to the ABC. And then Prime Minister Turnbull at the time said, you know what, we've got to do something about this. Now, it made some key recommendations, and some of these are in play, but yet to be fully implemented. And I think they're important issues. In relation to place, supporting, in fact, moving from a lot of independent funding of mental health organisations to supporting primary health networks nationally. The idea behind that, mental health had to be part of healthcare. So the biggest amount of money, over $350 million originally, transferred out of specialist mental health to primary health networks, supported the establishment of PHNs, with the idea that we have to be place-based. The situation in North Queensland is not the same as 10 minutes from the CBD in Melbourne. It's not the same as in the southwest of Western Australia. The system has to work as a series of coordinations. And really fundamental reforms, like actually taking the funding off Headspace nationally to actually be run through PHNs. A series of radical decisions to make it early days on that particular place-based set of issues. But the system issues, as Seb pointed out, of the disconnection between primary care, specialist care run by states, in particular NGOs and now the NDIS, really fundamental. And the problem is a continuous argument in our area. Put more money in, but more money into what? If you put it into that existing system, I'm not confident you'll necessarily get better outcomes out the other end of that particular system in a particular way. We have had this big emphasis on access. Seb pointed out the problems about the number of people in need who don't access care in our surveys. Unfortunately, largely for 25 years, and I blame myself and others as part of this, we put the emphasis on access. Community awareness is huge in Australia about the need. You see the Prime Minister saying last week, and now Prime Minister again, youth suicide will be a priority of this new government. The community awareness, the community demand to do something is very high. So what will happen in mental health, there will be increasing demand for services, demand earlier in the course of illness, but the issue around complexity needs to be recognised. Most people with mental health problems have complex problems. They're not simple problems. They don't go away in 4 sessions or 10 sessions. They don't go away usually just with one practitioner being involved. The 7I and others are involved in. We really need a system that supports team-based care, that brings together what different specialists and primary care and other psychosocial sets of issues, other social factors have to offer, that are orientated around what people actually need in the areas in which they live. That's a complex issue. As it is in chronic disease, as it is in other areas of the Australian healthcare system, we're not good at it. But while we fail to respond, what you're going to see is what you see at the moment. Increasing rates of people presenting to emergency departments, increasing pressure on GPs, increasing presentations and people saying it's a bad system. Interestingly, we've done some work with veterans. When people have a bad experience of care, then they tell other people, don't go for care. It doesn't work. That's really bad. We have many things that do work, but we have to create better experiences of care that recognise complexity. So I'm really glad that Tony raised the issue. I must say, I commend Tony in his role as the president of the AMA of actually getting involved in this discussion. Complexity is actually the issue. How do we work together across the different systems, across the different specialties that we have? The danger is at the moment, short-term other responses seem attractive. Throw money at this program, throw more money at better access, throw more money around to run off in their own direction to do something that appears to do something short-term for what is complex change. So I would say the thing that's been missing in this is actually professional leadership. Okay? There's a really strong need now to capitalise on the community interest with strong professional leadership. That's not sectional interest. It's not on behalf of psychiatrists, psychologists, GPs, whoever. It's professional leadership. And I think the AMA is extremely well placed to do this, to actually bring that national conversation to a sensible point of actually it needs to be place-based, orientated around people, recognise complexity, and then focus on outcomes. Not focus on where the money goes in, but are people actually receiving the benefit? Do they get the care when they need it, when they can, in various positions? And be smart. I'm personally tied up with other technology-based initiatives that are smart, that links the information systems around the people to get the right care when they need it.
Oh, thanks, Ian. That's terrific. Margaret, and just introduce yourself.
Yes, so thank you. I must say I was really pleased to be asked to participate in this panel, so thank you very much for the invitation. I'm a GP. I work in Brisbane here, so it wasn't too far to come. I think this is a really important area, as Tony already highlighted. In general practice, that's what we do. We do mental health all the time. So it's been interesting to hear what's already been said today. I agree about the complexity, and I certainly agree about the access issues at the time when there is suddenly a crisis point or whatever. It just doesn't feel like steps anymore. Suddenly it's all got messed up. I wanted to mention stigma because I think it's a very big issue. Definitely we have a community that talks a lot about mental health care. They did a study of an occupational group not that long ago, a national study in Australia, and they asked the people about work and about mental health issues. And 40% said that they felt that their peers who were working with them, who had a history of mental health disorders, were being perceived as being less competent. 59% said that they felt that it would be embarrassing to be a mental health patient. 7% said that you should actually be able to avoid mental health issues. I suspect that's if you try hard enough. Now that was actually the Beyond Blue study of doctors. So I think in our leadership, we have to think very carefully about how we understand the stigma of mental health issues ourselves within our own profession. Over 20% of psychiatrists in that study actually said that the lack of resources in their work was actually a significant stressor. So at the very time that we're trying to engage people, that they actually should come into the mental health care system, we actually have significant workplace issues. So I wanted to highlight the issue of stigma first. I also wanted to highlight the importance of delivering safe, quality care for people with mental health issues. And we can only do that if we look after our own mental health and it's adequately supported in the workplace, because moral distress around mental health issues is a really common problem. We need to be able to support each other. In hospital teams, there might be support, but sometimes the doctors, in particular the junior doctors, miss out on the support that's available. And for those working in primary care, Well, often they're very unsupported. So I'll highlight another survey that focused on one hospital down south, where it was noted that nearly 45% of doctors had been personally affected by family or intimate partner violence at some stage during their life. Delivering care to those who have been affected by family violence is clearly very difficult for those who have already been affected by that themselves personally. Doctors are not immune, and doctors can be affected by secondary traumatic stress, and we often don't even know what that is. So in primary care, our mental health patients are in fact patients with very complex issues. And only one part of their health issue that they present to us in our primary care sector is actually their mental health issues. So working at the coalface, some days every patient I see has a significant mental health issue, most of which I can manage in my own general practice collaboratively with the patient, often with my practice nurses, often with my admin team contributing, and I don't think those cases are even getting measured by our system. And then there are patients like Mary. Like most patients, she wouldn't describe herself as a mental health issue or having a mental health issue. She wouldn't describe herself as being a diabetic either, even though she has diabetes. She would describe herself as Mary. Mary's got chronic depression. She's had it for years. She's suffered for decades with domestic violence. She is very bright. She is highly anxious, and she lives in the poverty that symbolises the difficulties that she faced during her life. Her blood sugars are a barometer of her mental health. When her diabetes gets worse, I have found that more counselling rather than drugs are the best option for her. So it's hard to get Mary engaged with psychological support unless she can have trauma-informed care. Finding a psychologist within the mental health plan system that can provide trauma-informed care without out-of-pocket costs can be difficult. But I'm sure it's cheaper for the government to have Mary functioning at home, managing her diabetes, compared to the health costs that would be with poorly controlled diabetes, recurrent presentations. So these savings, again, are rarely measured when we're actually looking at the mental health economic data. The access is still an issue, though the primary health networks have certainly made a big difference and they're helping with the gaps in our care. There are still gaps. I can fix the diabetes with counselling. I can also improve many of the mental health issues if I actually have housing security for my patients and the other basic social health needs supporting my patients. I also want to highlight the needs of the CALD community. I think the CALD community need access to mental health care, and that means they need to have access with cultural and especially linguistic support. How can you do talk therapy without having interpreters? And I know some primary health networks have done very well in supporting that. The NDIS, getting a person actually supported through the NDIS if they have a mental health disability is very difficult unless they have more complex problems. If you add the CALD background to the mental health disability, it magnifies the barriers to getting onto the NDIS. And finally, I want to end by adding just a couple of points. I do not understand why we use the most amazingly linear approach, which what is a complex problem, when we visualise mental health care as stepped care. I think patients don't go up and down steps, as we've just heard. It is a complex problem, and I have no idea how we decided to use such a unidimensional visualisation of psychological support. I certainly think we're more clever than that. I also think that there is no missing middle. Unless we're actually trying to describe a tomato in this with its very thin skin and all the rest of the middle is missing, the middle that's all the squishy stuff inside and all sorts of different squishy stuff inside, because that's what's missing is most of it. Most of it is the middle, and in fact it's not actually missing. It's simply just not connected, and it's connectedness as well as leadership that we need when we're looking at complexity in a system, connectedness. Because if you're actually looking for the missing middle, it's actually in my general practice. And I invite you to come and see it with me.
Thanks very much, Margaret. David, just introduce yourself.
So, I'm Dave Mountain. I'm an emergency physician from Western Australia and also been on Federal Council as the Emergency Craft Group rep for the last decade, I think. I've just got a video to show you. This came from a mental health summit about 3-4 months ago. It was actually produced by one of my colleagues in Western Australia, Danny Fedovich. It's very confronting, and I think it tells you why we don't want to keep on seeing patients stuck in emergency departments for days on end.
Fuck off!
Don't be kicking the door.
No, get out!
Come on.
I'm not getting in. You're not taking me in there. Get off me. You fucking hands off me.
Come on.
I haven't done anything wrong.
I'm struggling.
I haven't done anything wrong. I'm sorry.
I know you haven't.
Get your fuck, please.
gonna
Tommy,
come
don't take me in here. I know what they're going to do to me. Don't let me go and do what's going on.
Nothing, we just want to come in
I
and
know
have a
what's
talk to you
going
and
on.
see what's on.
You know what they're doing to me.
No, I don't,
Don't fucking
Jet.
say anything.
Come inside
Don't
and tell
fucking
me
say
about
anything. My parents are in on this as well. Oh, man. It's not all been right. And people, those people in the city, you know what they're up to. They're following me. That's fucking not. That's not fucking. I know what you're poisoning me with.
Hello there. My name's Phil. I'm one of the doctors here in the emergency.
This is all about mind control. You're poisoning me with your olanzapine, and I'm not going to have it.
Just to keep
no.
you safe on.
No.
You're going to need to take her onto the back.
Oh. Yeah, right. Please don't do this to me.
Stop that.
This is all about part of the plan.
Sandy, just calm yourself down. We're helping you out.
You can't fucking bad as the rest of them.
Hi Sandy, is there anything I can do for you? Yeah, not a problem. Just swing your legs around this way. Do you need a hand up? Need. That's it.
What are you fucking looking at? Can you take me for a cigarette? I've been in this fucking place over 24 hours. Have you got a cigarette?
I don't. There's a no smoking policy here.
Fuck off with your policies. You can't stop me. No, you can't stop me. I'm telling you. Now you're fucking bringing them in again. Get off me.
Come on.
Get off me. You've got no right to do this. You're not helping me at all. Let me go. This is not okay. I want help, not this. Please, no. Excuse me.
Yes, Andy.
Where's my bag and everything? Oh, I don't have my phone or my iPad or anything. Can I have it back? Well, I just don't know what's happened.
Okay, well, you've been here in the emergency department for a couple of days now.
What's going on?
We're looking for a bed for you. We've waitlisted
Oh,
you a bed in
come
the
on.
hospital. I know, I'm sorry. Where are you going?
I'm off.
Watch out, you're unsteady on your feet. No, where are you going?
Sandy, is there anything that you want for breakfast? A cup of tea, coffee?
No.
Sandy, it's Adam. How you going? Good news, we finally found a bed for you. Just come for a walk with me and I'll take you to the ambulance and we'll get you there, okay? Just walk with me. Thank you.
I really want to go.
I know you do. It's the first step to getting back home, okay?
That's confronting for me because that's an experience that we see pretty well every day in our emergency department. So anybody who works in an ED knows that scenario, has seen that patient or somebody very similar to them. And it's one of the reasons I think we're very passionate about trying to find solutions that mean that people don't come to emergency departments for prolonged periods of time. There are very good reasons for people to come to ED, but not to spend 8, 12, 24 a week in an emergency department. And we've become a ground basically for the dysfunction in our system and a discrimination against psychiatric patients, where we're not providing solutions appropriate for that population. I'm not going to go through that, you can obviously read it, but hopefully we'll focus on the solutions afterwards. I'm just going to go through some of the reasons we're in this mess in the first place. This is a hospital I know very well. I'm not going to name it. But we see more than one patient a day who spends more than a day in the ED in our department. So that's currently we're heading towards 500 patients for the current year, and it has been more than that in the past. In the last year, we've had a 4.5-day stay for one of our patients, and in the last decade, we had a patient who spent over 15 days in our emergency department, in the main department, completely surrounded by arousing stimuli. There's also a massive increase in mental health attendances in our hospitals, and they're not the worried well that are flooding our emergency departments. These are sick people. And particularly got bad around about 2011-12. Some of that is clearly driven by psychostimulants and the meth epidemic that's going on in Western Australia, South Australia, probably other bits of regional Australia as well. But everybody's seeing the similar sort of increases around that time. We might think things are bad, and they are. So Australia has one of the highest rates of mental health disability in the world. We're the fifth most mentally unwell country in the world. Hard to imagine in a country that's so blessed, so lucky, so prosperous. Something's not quite right in the way that we're doing business. And we've obviously got increasing suicide rates, one of the few countries in the OECD that has, even though we've spent oodles of money trying to work out how to turn things around. One of the reasons is substance abuse. So actually we're very low in terms of drinking. It may not seem like that at the end of this conference, but we're not the world's greatest drinkers, but we love drugs. And we are very, very addicted to substance abuse, and particularly methamphetamine, or amphetamine type substances, which really drive quite a lot of psychosis and mental health dysfunction. Why do people spend so long in the ED? It's a pretty easy process, ED. It's sort of overwhelming sort of attendances at the front door, and there's lots of things driving that, and I've talked about that, including increasing acuity. And then all the disablers, all the things that stop people getting out of our departments. The things we've heard about, the dysfunction, the inability to do joined-up care. Anybody who's complex basically gets delayed in an emergency department because nobody wants to take on multiple problems at the same time. It makes it very difficult. And then terrible transport issues as well. Our attendances are getting more acute. So they're more unwell, they come in with higher triage acuity, they get admitted more frequently. And that's been carrying on for the last decade. So it's not, as I said before, the worried well that are coming in. These are very unwell people, often with acute psychosis. And it'll be no surprise to you that these are the groups that get penalised most. The ones who are the most disabled, the people who've got the most disability in our society, who are have the most other dysfunctions already attached to them, who then spend longer in our emergency departments and end up with, I think, very compromised ability to engage in care in the future, because if you've been through that process, you'll feel very much that the system is against you, and that it's hard to engage with people or trust them when you've been sedated, resedated and restrained multiple times. As I said before, the waiting times have increased dramatically, particularly in South Australia, but West Australia and Tasmania are particularly dysfunctional as well. I think Victoria's got similar issues brewing. But if you actually look at the numbers, it's extraordinary. 5,000 to 8,000 patients a year spending more than a day in an emergency department. Probably over 1,000 spending more than 2 days in emergency departments around the country. And if you think about that process there and think how harmful that is to trying to establish a therapeutic relationship, I don't think anybody does well. There are lots of adverse outcomes. I'm not going to go through these in any detail. The ones on the left-hand side are ones where there's papers showing those adverse harms in the past. The ones on the right, almost nobody has done any research on what the long-term outcomes are for people put through that process. But I can almost guarantee that all those things will get worse if you have to go through those prolonged waits. There are things we know that work. If you put capacity back into the system, if you actually have places to move people and you can get them out of your emergency departments, that works. But nobody really wants to fund it, and nobody wants to continue to sort of do the work to try and find those. Having supportive and coordinated systems where the patient is central to that and where you get them out of that toxic environment. And I promise you that an emergency department, I spend 12 hours there working, and I don't want to spend any more hours in there. So a patient's in a much worse position than I am. And we need some research and evidence. There's very little about how to make these things better, long-term research. So that's enough from me. I'm very happy to take questions. I do hope that people don't think the idea is to just keep on pulling more stuffing out of the mattress at the bottom of the cliff. Thank you.
Can I ask you to thank all the speakers for their thoughtful and thought-provoking presentations? So we've got just over, or almost 40 minutes for a discussion with you guys. But to start with, as I say, I'd like to invite Vinay Lakra to give his reflections, I suppose, on what he just heard. Might be worth just introducing yourself too.
Thank you. Is it working?
Yes.
Okay. Thank you, Sebastian. I am, obviously I have a role with the college. I'm a psychiatrist. I've worked in the public sector in Victoria for most of my clinical experience. I've dabbled in and out of private practice a little bit, so I do have a little bit of understanding how that system works. And I work with a lot of colleagues, obviously, who are in private, so I understand that. I've worked in acute inpatient units, emergency departments, long-term residential rehabilitation, community clinics, you name it. I've kind of worked across the system, and so I understand how the system works very well, or not so well. I work in the Chief Psychiatrist's office in Victoria as a Deputy Chief Psychiatrist. I've been there for the last 3 years, so I've got a good understanding of what happens across the state in Victoria. And I'm also the Clinical Director of one of the mental health services, and unfortunately, Tony, the two scenarios you talked about, your practice is in our network. So I'm really sorry that you had to go through that, because we've done a lot of work to engage and work with our GPs to support them in providing right access to their patients. But yes, it's very difficult to hear that sort of story. And that video which David shared, I was there at the summit, which was jointly organized by the College of ED Physicians and our college, with some actions which came from that. What I have observed over last, I've been in the system now almost 15 years, to the day actually. I started working in Victoria on 27th of May in 2004, is that we've somehow shifted the narrative about mental illnesses to an episodic illness, rather than it as a chronic disease. So we've just somehow reassured ourselves that if you've got depression, psychosis, schizophrenia, bipolar disorder, it won't come back again to you or to the patient. It'll just be fine. This is just one episode, and once we treat the episode, it won't come back. But that's not the case. I sit on the forensic leave panel in Victoria at the Thomas Emling Hospital, where most of the people who have committed a serious crime while they were unwell, and almost 90% of those people are the ones who have committed that crime in their second, third, fourth, or fifth episode. So they had an episode, they got better, they received the treatment, they got support from the community, they got discharged, eventually stopped their treatment, became unwell, had a second episode, and at somewhere in that second, third, or fourth episode, they'd commit that crime. And in a small proportion of them are who commit that crime in their first episode. And even then, there were plenty of opportunities for them to have access care to prevent that from happening. So there is a cost associated with relapse. There is a very significant personal, social, financial, community cost associated with every relapse of person with severe mental illness. In Victoria, we've obviously, there's a Royal Commission into the mental health system in Victoria. We only provide care and treatment to around half of the people with severe mental illness than what we should be providing. And then there are obviously solutions. So but unless we do things differently,
we'll come to those. We'll get to some questions. But thank you. That's very helpful. Look, I should have just mentioned a couple of things too. I said it was 7% of the mental health of the health budget in 1992-3 and in 2016-17. What's also important to mention is that it is 12% of the burden of disease. So I don't think necessarily there's a reason why it has to be one-to-one, but I think the gap between the burden of disease and the amount of funding says a lot. And in terms of the cost of readmission or the cost of relapse, as Vinay was saying, and to add to David's point, Australia is second in the OECD for readmission within 30 days for schizophrenia and third for bipolar disorder. So I think that bears out a little bit about what I was saying about the capacity of the community sector to provide an alternative to hospitalisation. Right, let's get to questions. So let's go microphone number 1. It might just be nice just to introduce yourself. Can't hear you, I'm sorry.
Is it on? Yes.
Can hear you.
My name is Magdalena Simonis. I'm a general practitioner at Victoria. And there is a sort of a disconnect between the services that are available and the patient. Between the patient, the doctor and the services that the patient requires, we need some form of linkage in the form of a care navigator. There's been a lot of research conducted in various areas and overseas in particular, but also locally there's been a research project through the University of Melbourne called a LinkMe project through a primary healthcare network through Jane Gunn's Department of General Practice that looks at having a care navigator who is appointed to be the advocate for a person with special care, mental health requirements, to enable them to actually get to their appointments, take their medication.
So there was a thingy called Partners in Recovery, which existed and was funded by the Commonwealth in a broader scale, which did some of that work, and it was subsumed into the National Disability Insurance Scheme. So that program no longer exists or is about to be erased.
Yeah. However, I think that we need to revisit the things that have worked.
Yeah.
And when we are floundering to find solutions to such an enormous and endemic problem, because in general practice we are inundated with these issues, and as Tony has described, we've all been in those situations, you know, and I don't have the answer for acute care beds for patients with severe mental health issues, but for the chronic disease that is not being managed in the outer community, then we need support with someone who can actually be the advocate and a care navigator for those individuals.
Thanks
and I think
very
we
much.
need to revisit that.
Thank you very much. Microphone number 2.
My name's Ines Ree. I'm a GP. I'm chair of the GP section, and I'm also the chair of the North West Melbourne Primary Health Network. There's a number of themes, I think, that come through here, and the themes that we actually need for success. One is the place-based solution. One is the strengthening of the patient-centred medical home in a GP-led model, which actually incorporates some of the aspects that were talked about there, but also by Magdalena. And the third thing is an integrated systems response with a single door, so that we as GPs and our GP team, and also, very importantly, the person and their carers, can access things in an equitable, timely way. And then underpinning those are some prevention aspects that you've talked about, particularly substance use, and I would add to that issues with young children and neuropsych trauma that we really need to think about. My concern is that the politicians seem to want to fund nice, shiny things that are packageable and don't have the complexity of actually dealing with those, I think, 3 major things with some undercurrents. And I'm scared that their current trajectory will actually end up with more fragmentation and more problems. And as Ian said before, this is all about outcomes, and we really need to measure this along outcomes. So I suppose my question is, how do we stop the government actually saying, we will just fund these nice, shiny things without actually real systems change that is required?
Professor Hickey, there's no need for concern about fragmentation, is there?
What you're going to get, what is about to happen is more fragmentation. Okay, this is where I think the professional leadership issue is critical. The current drivers for increased funding will lead to more fragmentation. Okay, because the shiny new things are programmatic, there's certain kinds of MBS items, there's certain kind of professional services, each seen to respond to a specific thing. Now, they're each seen to solve something. You know, there's a problem of this, so we do that in a particular kind of way. The complexity of mental health problems within the complex thing that is the Australian healthcare and psychosocial disability systems, between the two of them, has proved unresolvable to this point. So I think this is a point of stopping. I think there's a tremendous opportunity here for the AMA to stop and go, you know what, we're all interested in bringing that together. It is a complex set of issues. There is not one program that will actually solve it. There is not one MBS item that will solve it.
I agree.
There is not one profession on their own that will solve it.
Not one government department.
There won't be one department that will solve it. There is someone in the room from Prime Minister and Cabinet. It's a whole government thing. You know, there are housing issues, there are transport issues, there are welfare issues, there are education issues, and there are big health issues. And transferring about navigation got moved out. National Disability got taken and said it was not a health need, it was a social need in a particular way. So we keep undoing some of the better things, but right at the moment, the pressure at the moment to put more money in will lead to more fragmentation unless the professions say this is a mistake.
I agree completely.
So I'm going to ask David to make a comment because he wanted to, but I know that there's lots of people want to talk, I want to say, which is great. Can I ask you to think carefully about the question you wish to ask the panel as much as possible, so we keep as focused as possible, get through as many questions as possible. David, you want to say something?
Just with one of the issues is that so many of the programs that we do are just not properly assessed. I mean, you want to see changes in people's trajectory and their outcomes. Do they have to keep coming back to hospitals or emergency departments? Do they actually gain employment? Do we find them housing? Yes, that's a social issue, but it really affects their long-term ability to manage their mental health care and their physical health care. Do they actually stop dying of physical diseases 20 years younger than the rest of the population? And our programs should have to be assessed on that, and we should defund the things that don't work and, of course, increase our funding on the things that do work.
That's the hard one. Taking the money away. Now, mental health, we have moved the money to the primary health networks so that the primary health networks and a lot of the professions now have responsibility for over $400 million a year of mental health money. Okay? So we've stopped actually a whole lot of little programs, which has not necessarily been a great thing, but we have an opportunity. And the continuous defunding of less good options in favour of better options is one of the biggest challenges.
So, microphone number 1.
Rob Parker, psychiatrist, Darwin. I've actually got a question from Dr. Jeff Louis to Ian Hickey, asking him what a professional administrator is. So but I've got my own questions as well. Firstly, funding is a real mess with the state-federal issues. Are there models from overseas where they've got more unified health systems, such as the NHS or New Zealand, which show a more effective use of the mental health dollar to prevent some of the issues you're talking about? Secondly, stressing mental health is different to mental illness. As a psychiatrist, we deal with mental illness. Mental health is a much more population-based issue, and I'm still convinced that education programs in school have probably got more bang for their buck in preventing a lot of the stuff that David's seeing in ED. The third, the navigator issue, I mentioned it in my submission to the Productivity Commission, submission number 12. I think a real problem for us at the moment is other issues in the mental health workforce, particularly mental health nursing. We've had shifts in Darwin where we've had one experienced mental health nurse in our high dependency unit with 3 or 4 locums. And I think that's going to be a real problem for service provision in years to come.
Thank you. So, do you want to talk about
just very briefly, Rob, if people don't know, the Productivity Commission is looking at mental health at the moment because the funding situation is so dysfunctional, it's so fragmented. The response of the professions and others to that report and the draft report in October will be critical. Government will do nothing in relation to complex issues like that it will produce if there is a lot of professional pushback. So that's all about how we bring it together. I personally think through the PHNs at the moment you can get cooperation in regional areas without necessarily pooled funding. But the commissioning of better services, evidence-based ones that are person-centric, is undoubtedly what the Productivity Commission will recommend. It won't necessarily fit with a lot of advocacy for this MBS item or that new program or this particular initiative in a hospital. So it's going to be one of the really big social challenges. But it's not right. Say, Rob, the issue is, and recommended by the National Mental Health Commission, is got to have a Productivity Commission review. Got to have an economic look at where the money goes and the way we spend it currently, the services we currently commission, are they smart or not?
And to answer your question, there are some examples in other places, but we might about funding and about arrangements, but maybe we can talk about that later on. I can meet you over dinner and a very large glass of red wine or something. Not that I'm promoting comorbidities. Microphone number 2.
I'm Nitin Dawadka. I'm a council member from Victoria. I'm a psychiatrist. I think mental health, thank you to the panel, but since we don't have any carers or consumers here, I'll try and advocate for them just to remind myself and everyone here about the data of suicides. So suicides in 2016 to 2017 went up by 9% to about 3,200. That equates to about 9 suicides per day in Australia. So I think one suicide is too many, but just to remind ourselves that it is a very major issue. Now, with mental health, and I'm only talking about not the mild or the very severe end of the spectrum, which do get admissions into hospitals, but about the moderate to severe, where there is less risk to self or the community, and that is the area I'm talking about. So I heard, I understand that there is a rollout of 8 Headspace-style adult centers announced by the Prime Minister's office, which will be I think they are far too less, but I'm also worried about the fact that they are being rolled out, but we don't really know how sophisticated they are, who will be manning them, and whether they'll be enough or not, and whether they really are going to answer any of our issues, and whether there'll be further fragmentation. So this is a question specifically directed at Ian Hickey.
That's a great question. Ian?
Well, there was a budget announcement in the May budget around some sort of adult coordinated care centres. I mean, there's meant to be
8 of them, yeah.
So they use the terminology Headspace to give it a kind of idea what it would be. Now, my understanding of that is actually for design and experimentation, that this issue of bringing things together rather than making them less fragmented. I personally have expressed reservations about that going down that track of yet creating another set of centres in particular ways. But it does come to the issue of the coordination of more specialised levels of care for the middle that you have been describing in an ongoing kind of way. In a sense, it's meant to highlight, I think, the problem that's been highlighted already by Tony and others here of the complexity that is ongoing and how is that ongoing care actually provided. Now, I think the issue is in here, and having a great seat next to 2 GPs, is how do things really work in a primary care setting? The issue of healthcare homes arose in conversation a moment ago. What are the ways in which we can coordinate ongoing complex care in the community? So that money is meant to do that. Now, I think what you've immediately seen is a kind of bricks and mortar solution. Okay, we'll create another set of centres. I personally feel we have to look at things in a more complex way, in a more sophisticated way than that.
I think the Prime Minister has also announced that there will be a special advisor looking at not only mental health, but related issues like accommodation, social, financial, legal. And I would urge the MA and Tony to have a conversation going with the Prime Minister's office so that the MA can also have input into that, because that is supposed to be to make it more cohesive, all the resources.
My view about the Headspace is just to say that I think this is, you talked about, and I think somebody talked about the role of professional leadership, and I think the idea that you could look to establish a structure like this without having the broad level of engagement of professional leaders in helping shape the design of that is it doesn't really fly with me.
Yes.
And I would go further to echo the point you raised. Any type of service type response and design surely has to engage consumers and carers to make sure that they're places that people want to go. And that would need to happen as well. So David, you were going to say something.
Well, again, a lot of these centres are still on a sort of fairly daytime, Monday to Friday basis. Most people actually feel worse in the middle of the night or on a weekend when they can't access service. And, until we start to design things that actually meet patients' needs when they actually need care, we're going to continue to sort of wonder why they keep on presenting to emergency departments, because they actually need access in the community at least 16 hours a day, 7 days a week.
Thank you. Move on. Microphone. Okay. Thank you. Microphone number 1.
Suzanne Davey, Canberra GP. I'm used to psychiatric care being a large percentage of my workload, but what concerns me is that I'm having to treat younger and younger adolescents and children with psychiatric disease, and we all know these conditions present often in childhood and adolescence, and it's a lifetime of psychiatric care if they don't get early intervention. Well, my problem is simply access. In Canberra, in the private and the public system, there just isn't access to psychiatrists. There aren't enough psychiatrists on the ground. And that's what I ask you. Are we not training enough psychiatrists? But I need help to manage these very difficult children. And they shouldn't just be relying on general practice. The system should be able to support GPs if this is what they have to do.
Tony, do you want to make a comment?
I think Suzanne's articulated the problem quite beautifully. Look, you're right, Suzanne, the access has been the real crux of the issue for me. The linkages, the coordination of that pathway, that journey through the system is also important. I've talked about building up the capacity, capability and infrastructure in general practice to allow us to do more of the grunt work, more of the heavy lifting keeping patients in the community for longer before the need to present to more specialised services. But we do need that backup support. Now, Ian and I have had multiple conversations about leadership, and yes, it's something that I do intend to ensure that we do take a front foot on, because there are too many people with ideological or self-interest at the table at the moment, with a lot of potentially still yet to be really evidence-based methodologies in terms of how to deal with the problem on a limited health budget. We need to ensure that we've got, and this is where the leadership I think is really important, is to get the players all together to sort of leave their baggage at the door and work out on a structure that deals with federal and state divide, that deals with the complexity of not just the health burden, but also the social burden, the housing burden, the economic burden, the work-life balance that is required, and all the other parts that go into that system to managing a patient with complex and chronic needs in that regard. So there's a lot to do in this space, but it does need, it needs an overarching strategy with all the people agreeing, and then get the appropriate funding and get a clarity of purpose. The Productivity Commission will obviously look at the economic argument, or the best way to get the bang for your buck for a given dollar, but we still need to have a clear idea of what the strategy is, and have a clear idea of who's doing what in the system, and how to improve that infrastructure right across the system.
What did Paul Keating say? Paul Keating said, I think Paul Keating said, in the horse race, always back self-interest, because at least you know it's trying. So, Ian, you're going to say...
Just a quick response. Obviously, the issue of assessment is critical. So the change in work practice of psychiatrists towards assessment to support all these issues is critical. So there's actually, and how you do that through professional leadership, through funding mechanisms, through other things, to get the assessment bit, particularly around young people. You're going to see more and more young people come into the system at younger ages with complex presentations that don't fit easy diagnostic systems, needing care. So the role of psychiatrists in particular in the assessment phase of that early, not late, not in some dumb stepped care way after everyone blind Freddie knows what's wrong, but early when it's complex, is exactly what is required. That's a professional leadership issue and a funding and organisational issue.
Thank you. Microphone 2. Thanks for your question.
Hi, my name's Tony Joseph. I'm an emergency physician in Sydney, been so for 25 years at one hospital. I've got a clinical question to the panel and to Ian in particular, to represent the psychiatrists, about a group of patients who present. There are a small percent of the group of psychiatric patients who present. I mean, ED, we manage acute psychosis, overdose pretty well, but patients with borderline personality disorder or personality disorder are frequent presenters, often with suicide or parasuicide attempts. Very difficult to manage in our departments. You often know when these patients are in the department because the whole department's in an uproar. And it seems to be psychiatry is somewhat withdrawn from the management of these patients. And I'm just wondering, is there a better way to actually manage these patients in the community so they can actually, because coming to emergency department doesn't do them any good, because I don't think we have really much to offer them. Is there a better way that we can manage them in the community so they can prevent them coming in?
It's an ongoing management model. I point to the work of Andrew Channon in Victoria in particular. First of all, you have to agree they have got to come in, they have a right to come into care. Secondly, if you follow them up, picking up David's earlier point, they have just about the highest mortality rate of any group that we look after. But we've fallen into a dumb system of somehow, because we call it personality disorder, of being excluded from care, despite the healthcare costs of premature mortality. So there are systems, but they require a commitment to ongoing serious care for that particular group. So in the debate going on around MBS items at the moment, in terms of actually providing prolonged and specialised, actually good care, smart care, I'd make another comment. It needs people who know what they're doing with those people, okay? It's not something that every Tom, Dick and Harry counsellor can actually deal with. So it requires skill and it requires commitment to systems that actually meet the needs of that particular group. So the current debate about how to use MBS items differently, that should be a key discussion.
Thanks a lot, and thanks for your question. Microphone number 1.
Hi, Michelle Atchison with the AMASA. I'm a psychiatrist, I'm a private psychiatrist, and I'm the chair of the section of private practice psychiatry with the College of Psychiatrists. Sebastian, when you spoke at the beginning, you spoke about 3 separate streams looking after people with mental ill health. You talked about primary mental health care, the state services and the NDIS. we kind of have forgotten, I think the speaker just before touched on, well, there's a whole group of people out there who are private psychiatrists. Probably about 40% of psychiatrists in Australia work in private practice psychiatry. We are the people who can help you deal with borderline personality disorder. So mine is a call for not forgetting that there's private practice psychiatry out there, for integrating that in any model that you develop. And also, I think the second point I'd like to make is about integrating psychiatric care and drug and alcohol services. There's been a huge divide between psychiatry and drug and alcohol services. If we can do something to bring those two groups together, then people like yourselves in general practice faced with those complex problems, people in the ED department don't have a drug and alcohol person and a psychiatrist coming to see them. If we can integrate those services, I think it would be fantastic.
That's really helpful. Look, I should just clarify. I think you're right. I think that psychiatry generally has a role in this leadership we're talking about. But I would just say that the rate of growth of psychiatry, it gets to the previous question about workforce, over the last decade, actually since more than a decade, psychiatry under Medicare has grown by about 5%, whereas psychology has grown, registered psychology has grown about 100%, and clinical psychology has grown something like 200%. So the question really is, how are we making the best of our workforce? Are we using them in the right way? Are we working with them in the right way to get the sort of outcomes that you're looking for?
Well, that's a little bit of a circular argument, because the increase, of course, is to do with the better access system. It's not because people are, would have chosen to go to psychologists.
I guess it's for me, it's just a bit of a confusion about role delineation and about whether we are confident that we've got people working in the right way to deliver the right services to the right people at the right time.
Yeah.
So, did you want to say something?
Yeah, I mean, I think it is a real problem, the complete fragmentation that's going on throughout medical systems, but particularly in psychiatry. And I think the constant denigration of psychiatrists within our healthcare systems and often within the public, media and their present, they are absolutely essential for running team-based care, which is what most of our patients, and liaising with other teams, drug and alcohol, physical teams and whatever. Liaison psychiatry, I know that they're trying to cut liaison psychiatry in multiple hospitals in Western Australia at the moment. It will be completely disastrous. So we need to increase the number of psychiatrists. We need to reinforce the fact that good care only happens when it's team-based and when somebody actually is able to coordinate and guide that care.
Yeah, thanks, David. Thanks for your comment. Microphone number 2.
Sally McCarthy, I'm an emergency physician, have had a long involvement in various mental health task forces. I was on the Prime Minister's ICE task force. And my question really encapsulates a lot of what we've already touched on. But I think one of the core, there's sort of 2 core issues. Ian's already talked about this, governance of the broader mental health services, and I'm including everything to do with providing that service, and where we've got so many different services. I work in a tertiary city ED, but I also work in a very small 6 hours away from any tertiary centre rural ED. And despite the existence of quite reasonable services in both those sites, within the mental health services in the broad brush, there's a breakdown of collaboration, and the culture within that service or the service providers seems to be to avoid taking on patients, even though they themselves are maybe managing them in the community when they have to come to the hospital. There's no streamlined entry point. There's nothing the ED can do. It's a known patient. So I'm really pointing to the need for culture change within that broader mental health service to really embrace and pick up patients. So my question is, and I use the example of the organ and tissue donation task force that we had to bring hundreds of providers together some years ago and better design a national system. So that I think there's a necessity to for everybody to get together to look at the governance and culture and how's that to change. So
you're calling for a Bob Hawke style summit?
Well, look, I think we've seen over so many years, so many different groups trying to fix this, and it's not really working.
Ian, do you want to comment?
Totally agree. but the issue about it's very easy for everyone to sit around in their own individual groups. I mean, Sebastian and I have been, if you haven't noticed, very critical of psychology in a number of these areas, but the same thing's true within the medical professions areas. Everyone can sit in their own thing and say, yeah, it's not my problem, it's our problem. Right? So the collaborative kind of working together thing, because otherwise there is only one alternative, and that's the emergency room, where the light's on 24 hours a day and it's open, and as David has shown elegantly, it's the worst outcome for everybody. The rest of the thing is going on the rest of the time. So I think it is I actually think it's a collective responsibility issue. And I'm keen about the place-by-place, region-by-region kind of approach, the governance bit of people participating locally in the solutions within their health districts or within their PHNs or as groups. But that requires some serious national oversight of where it is working and contrasting in the bits where I know it's working, there is strong local cooperation that needs to be highlighted. And where it's not working, everyone's sitting around going, it's not my problem.
Completely agree with you, and there are outstanding examples, and we've probably all experienced those, but the thing is the answers are all there, but they're just not spread across the system.
Yeah, and clearly there are funding and structural issues, technology that can support that, but without actually a willingness to go down that track collectively, we aren't going there. We're all going to sit there and argue for our own individual bit.
And as taxpayers, we all want effective and efficient use of any funding.
Thank you. A great point. Microphone number 1.
Hi, I'm Steve Gourlay. I'm another emergency physician. I'm from Alice Springs. Firstly, thanks, David, for your presentation, and I agree with you, keeping people in the ED for long periods of time is cruel and unusual punishment. We also have, we have to move away from the idea that all the services are solar-powered. We need extended care. My question to the panel really is around prisons, and I feel that we've let down a significant proportion of our community, particularly Indigenous people, where they end up in our prisons because of a lack of coordinated care. It's weird, or it's very sad to me, where I see people doing better because they're in prison than they are because they're living in the community. What's your take on that?
Who'd like to answer that?
Well, there's another easy one. Just on top of the other. So the National Commission did look at emergency departments and prisons.
So the question was really around particularly around the, I guess, poorly integrated response to the needs of Indigenous people, which leads to their incarceration.
Well, it's about prisons generally and the Indigenous.
And particularly around other Indigenous people.
That's again, I mean, we find it very hard even to do a joined-up psychiatry system, and then we add in drug and alcohol. That's very difficult to just coordinate those two. When we then have to factor in all the social issues that drive, a lot of the disability and the mental unwellness, a lot of governments just seem to be completely incapable of thinking of that sort of joined-up systems. I think places where things have improved and where Indigenous care is better, that is when a whole of government approach is taken, and you actually try and sort out all the problems. Obviously, you can never do it all in one go, but you've actually got a thought that I can't just do this stuff in isolation. Everybody has to be involved.
Thanks very much, David. Microphone number 2.
Jason Wu, Paediatric and Emergency Registrar, New South Wales. My question is mainly to Prof Mountain. I was an ED advanced trainee, but I've decided to leave my training, even though almost finished. This is because of the violence. In my department, for instance, we've had 6 staff members stabbed in the last 8 months because of patients being cohorted for days within the emergency department. And this is an issue that's been debated. Yes, mental health patients in emergency departments, also safety in New South Wales. But what will it take for the federal government, because this is an issue that's been debated 6 years ago when I was a medical student, still the same questions going on. Will it take an ED doctor to die before something is actually done? I just don't see any action being done on this issue.
Well, it's a very topical issue in Western Australia. We've just had a nurse, she wasn't stabbed in the emergency department, she was stabbed up on one of the trauma units in the hospital. It has focused the minister's attention, and again, lots of worthy words, but what we'd actually like to see is some actual money and some actual doing of something. So the fact is that one of the things that does make places safer is when there's a visible security presence 24 hours a day, when you've got people who are immediately available so things can't escalate, so that you can actually search baggage for people who are clearly upset, agitated, unwell. And then you can provide better environments. Of course, the other thing that you could do is actually make sure that people don't spend insufferably long times in emergency departments, because it's guaranteed that they will be agitated and upset after they've spent that amount of time in an emergency department.
Sebastian, can I just make the point? It's just, I don't want to trivialise the work health and safety issues for staff, but the number of patients that have died already in these settings at the hands of security staff and others in these unsuitable settings is already large. Okay, so while we're concerned obviously about the welfare of people who work and the staff, these are unsafe environments for everybody, and particularly for the patients who come into that thing. So I think what David's video so tragically highlights is how inappropriate it is for the person in that situation. And the ongoing consequences for life are very large. Yeah. So I think one of the issues is a whole setting issue, is we've got to get out of this kind of setting as in any way appropriate. And then the rapid transfer, as Dave's made clear, any prolonged period of time in that setting, any unsafe sort of set of issues, there's repeated exposure for the patients and the staff in those settings. So the issue, of course, for us is that hospitals, primary public hospitals, are run by the states. You know, when you talk about the federal government's role, I mean, there is an issue here. These are run by the states. And I think this is under, again, local. If you change an emergency department around coronary care, cardiac care and stroke care and other, it's usually the professions at the end of the day who say enough is enough. You know, that's where the leadership actually comes from in terms of changes. We've seen this around seclusion and restraint. We've seen it around other issues. It's actually at the local level. Hence my plea for professional leadership being the key thing, and not individual professions, and why I'm very happy to be at this AMA meeting. It's a collective thing. It's great to see so many emergency room physicians along with psychiatrists and GPs in this particular session. Okay? It requires a collective response, and I think the professional leadership is clearly medical, and to say enough's enough for us and for the patients we serve.
So, Mike, thank you for your question and thanks for the answers. Microphone number one, we've just got a couple of minutes left.
Okay, Paul Bowd's my name. I'm a paediatrician from Darwin, and my question to the panel is, what role do you think racism plays in Australia's growing mental ill health? And I want to speak to a couple of issues that worry me. Dave Mountain spoke about our blessed, lucky and prosperous country. In our blessed, lucky and prosperous country, we've had 13 suicides of predominantly young Indigenous people. And the findings for this were that basically, along with many other diseases, this was a disease of poverty. The second group, and Ian Hickey spoke about the Prime Minister's priority for youth suicide, when we've had, over the last few days, 14 people on Manus attempting suicide because of a situation which has been developed primarily by our current Prime Minister. And I just wonder about how serious the government is when we have these examples on a daily basis.
Thank you. Great question. Ian, do you want to? Or Tony?
Well, I commend Tony for the role. In fact, the AMA, I think, has been very strong on these issues.
I should just say also that Beverly has given us the thumbs up for another few minutes after this, so don't panic if you're in the line. I'll try to get things going. Tony, thank you.
So, Paul, you clearly know the leadership that this organisation, this association has taken in respect of that. Clearly, we haven't had the opportunity to have a really meaningful and robust discussion post-election with the Prime Minister and with his whoever the immigration minister should be. But clearly, there is a need to look at that whole area or those whole reports that you, in terms of the second part of your question, and Manus. I need to sit down and really try and make sure that the same commitment that was in Parliament before the election remains the focus. And we've heard, you know, the work that IHAP has done, you know the work that our representative on IHAP is doing, so it remains to a topic. In terms of whether the Prime Minister's understanding or commitment, we'll have to take that as something that I'm going to have to talk to him behind the closed doors and make sure he fully understands. But back to your first question about racism, I think it's not just racism. It's really unfortunately it may even be the stigma, maybe the whole issue or the labelling of a patient being labelled as with a mental health condition. Throw in anything else, any other label you want to put, any other badge, and yes, there is, but that's as much a health literacy and an understanding point of view. Margaret made a point about CLD services and access. Language is really important. Being treated in a culturally safe and appropriate manner is very important. We know that's relevant regardless of your background, your racial orientation, and it's really important that doesn't become another hoop through which we have to deliver the services to a marginalised part of the population.
Thanks, Tony. Margaret, you want to say something?
I've just got one comment on that, and that is that the expression of our illness is very culturally based. So the expression of our mental health illness is often very culturally based, but similarly our expression of our physical illness and our reaction to our physical illness is culturally based and is often misunderstood if we're brought up in a biomedical Western sort of training. When we actually see a presentation that seems perhaps as a mental health issue, may actually be a physical health issue, and predominantly. So it's not been uncommon for me to have to slowly unpick what's going on, only to find that in fact it's very clearly a physical problem, not a mental health issue. It's presented in what I would have thought was a very unusual presentation, completely culturally based. I think we're terrible at understanding that.
Can I also just say, in relation to the Indigenous suicides in particular that you raised, and I'm thinking here about the work of Jerry Georgiadis and the National Critical Incident Response Unit, and thinking about what he talks about in terms of crashing poverty and so on in these communities. It raises for me the whole issue that the most important response in relation to suicide prevention is not likely to be from a mental health professional. And I think that raises a whole range of issues about how we respond, who's best placed to respond, and what should be the key ingredients of that response. So I think it's a really important issue. Microphone number 2.
Hi. Rebecca Wood from WA again.
I'm sorry, I couldn't hear that. Could you hear that?
Hi, Rebecca Wood from WA.
Thank you.
My question is mostly to Dr. Mountain as a representative for the emergency physicians in the room. What is your opinion of the use of mental health observation areas in the emergency department? Is this the solution to the problem that you presented in the video?
Is it a solution? It's a partial solution to some of the issues that we're going to deal with, because the problems are so large and they're so endemic now that they won't get turned around in a year or 2 years. So you have to have other options. It is certainly much better for patients to be in a quieter, better observed, more calm environment as quickly as possible out of the main ED. And if you have behavioural assessment units or mental health observation areas that can, give you that ability to let somebody calm down, sort of accept some treatment, give them some options, that is a much better place for them to be. I can guarantee you that they won't get better and they won't improve while they're in the main emergency department. So yes, they're a symptom of a system that's lost its way, but I think they will be essential as some of the ways for us to deal with this problem for the next decade.
Can I just say, I can't resist. I think we could spend time thinking about how to make the ED work better, how to make it safer. And I think that's not necessarily a bad discussion to have. But the places that have gone further in terms of shifting their mental health systems have done more to obviate the requirement for hospital admission. So they don't come. They're in the community, they're in their homes, and that's where they receive primary, secondary or tertiary care. And that really seems to me to be a discussion that we should be having.
There are clearly systems that have changed how you deal with community-based acute flare-ups in mental illness. So Holland, now there almost no police ever go to pick up a patient in the community unless there is clearly somebody who's trying to use a knife or something. But in general, so police are one, not that well trained in dealing with these situations, and two, police are often a stimulant towards sort of aggressive behaviour. So, and they found much lower rates of requirement to go to emergency departments or hospitals, much more de-escalation when they've actually managed to move police out of there. Whereas in our environment, in fact, police are recalled more and more to those sort of disturbed behaviours.
New Zealand has an acute ward in a house, not in a hospital. Microphone number 1.
It's Nikola Ognjenovic. I'm an addiction medicine specialist. I can't help bringing up this issue. In Queensland, in Brisbane, we used to have a youth mental health facility which was closed down by a previous administration, a long-term, long-stay facility for mental health use. And within weeks, 4 of the previous clients committed suicide. I can't help also thinking, when you talk about 3 streams that deal with these patients, I think there's a 4th one that deals with these patients, is corrections. If that patient who was shown on that video punched one of the police officers, would have well ended up in a watch house and not coming to the emergency department. These people, if you dealt with the mental health patients, you know they are vulnerable. All they need is safety and some continuity and familiarity from their carers. Now, this fragmented model of care that we're providing does not provide any of that. When they're in an acute care facility, they're somewhat stabilized and then deemed to be thrown out to the community, where a case manager who also looks after 30, 40 other clients supposed to look after them. So there is nothing in between community care and the acute care that could hold these people. As a lot of them don't have social network, they don't have a home, they don't have anywhere really to go to. They end up in emergency accommodations, start using drugs or continue using drugs. So what I can't help asking myself and people who think about these issues, whether we should bring back that long-term residential care for people who are unable to manage their life with their mental health. And I grew up in a time when, as a psychiatry registrar, I worked in a big mental health facility with long-term residential patients. And I'm not calling for bringing back the old mental asylums, but something in that capacity and keeping the good things that these places used to provide patients.
Okay, thank you. Does anybody want to comment on the merits or otherwise of the re-establishment of long-term psychiatric care?
I'll talk to that.
Vinay.
Yes.
I might ask you to stand up, I think, so
I'll
everybody can
stand up
see.
again. Yes. Thank you for raising that question. That brings in a discussion about the number of beds. And I think I've got quite a few colleagues here in the room who've done a lot of work around the requirements for number of acute beds, number of long-stay beds, residential rehabilitation, secure versus community. Certainly in Victoria, we have access to some long-stay secure beds, not enough, and I think that's what we're kind of referring to. And so that discussion about beds in terms of long-term residential rehabilitation, secure and step-down processes is an important part of it. But what you've mentioned previously, most of the mental health treatment happens in the community. It does not happen in the hospital. We see lots and lots of patients which are provided treatment in the community. And we can pick up some of that early, provide care to them, and continue to treat them. There are plenty of examples in the current system where long-term treatment happens in the community and people say, well, close-up in shared care is a good example of it. Once you're on close-up in shared care, you're linked in with a psychiatrist in the area mental health service. You go and see your GP every month, and you stay well.
I'm grimacing because you seem like a really nice man, but you are Victorian. That's why I'm grimacing. And look, I'm sorry, but my understanding of the way things work in many other parts of Australia is that long-term, community care connection is missing.
Well, I think even in Victoria, we've kind of lost it. That's why we've got a Royal Commission in mental health system there. But what I think Ian pointed, and a few other people have pointed out, we need to look at systems and models of care which are working well and implement them and take away things where we're just throwing money into things which are not effective. Do we have, there is a Victorian Comprehensive Cancer Care Centre right in the center of it. Do we have a centre of excellence for mental health? Do we need to invest into it, to research into in terms of, providing that sort of care? And so, yes, occasionally the discussion does come about beds and it does come about, whether we should go back.
past is always nice. And I think we just need to be very, very careful about that.
Thanks, Vinay, and thank you for the question. Microphone number 2.
Why does it have to be either or? Gino Pecoraro, gynaecologist from Brisbane. Why does it have to be either or? It seems that a lot of these problems developed when we closed hospitals and there was no beds to put people in. In that situation that Dr. Mountain was in, if we had a mental health centred hospital in the city, that person could be identified as not needing to go there but needing to go to that hospital. If you had a specific hospital for mental health, it would be easier to train nursing staff and to get more people training through. From my neck of the woods, if it's after 3 o'clock in the afternoon or not Monday to Wednesday, you can't get a psychiatrist through any means at all. They can send you a nurse counsellor or they can administer a questionnaire over the phone, but why can't we have both?
Sebastian, I think we need to deal with this kind of the past was better than it was. I mean, in truth, a great majority of people were actually not treated in our past models. A small number of people came into certain kind of care settings. Demand for mental health services is going up. There's some evidence is going up in younger age groups. So we face demand characteristics now requiring a totality of more services and more range of services within that, including longer stay residential, step up and step down sorts of facilities. So I think the issue is we need the whole spectrum of services, including availability for the particular as alternatives to the obvious ones we saw in the video. But we have to think about how we grow the totality of that. At the moment, there's a government thing about throwing money at one or the other. Every time you open an acute in-hospital bed, it costs about $1,500 a day to do that.
That's right.
In fact, more of state budgets is going into the acute hospital sector than ever.
That's right.
For which there are no then alternatives to that. So getting the right mix across the board is actually the challenge, so that there is flexibility or availability in the system. So Sebastian himself has spent a lot of time at the step up, step down type things. You need to have transitions in care on the way in and on the way out, including longer term residential and secure facilities. So that whole spectrum thing is so unsuited to planning in the Australian healthcare system, where we throw money at one bit or another as controlled by a state government or as controlled by MBS items or as controlled now by the NDIS or in the prison systems, etc., as distinct from all of the people we're concerned about. They're our families, they're us. They require a range of services and may require different services at different points in that illness journey.
And before you build anything, ask the consumers and their families if they'd like to come. I think that's really important. Microphone number 1. Thank you for the question.
Thank you. Sarah Whitelaw, can you hear me?
Yes, I can now.
Sarah Whitelaw, I'm another emergency physician, but I think this session demonstrates how this issue is such a cross-profession issue, and it is imperative that the AMA, as a body that can access those opinions across the entire profession, not limited to groups within the profession, continues to be a leader in this area. Thanks for showing the video, David, from the patient perspective. What we missed was the impact on the other patients, visitors and staff in the emergency department that day, including the moral distress of not being able to give that patient the care that they need. We missed the hours wasted in trying to find gaps in a system that is always at over 100% capacity, that divert us as clinicians away from patient care. We missed the delays caused by the patient being too sedated when the ambulance arrived, which often happens, so the clock starts again. And we missed the impact on the patient's family and the patient when the bed that was finally found that lovely woman was transported to was in fact far away from where she actually lived. What we also missed was the impact on the patient who was discharged early from the psychiatric bed in order to accommodate, finally, the transfer of that emergency department patient. Our mental health presentations at the Royal Melbourne Hospital have quadrupled in the last 5 years. I have 2 questions, finally. It feels like we have been discussing this for many, many years, and I'm so grateful for Tony's continued focus on the issue and everybody's, I guess, all of the work that has been done on this. Are we at the point, and we're facing the Royal Commission in Victoria and trying to work out where we can have the most impact. Are we at the point where we can say at a local and at a systems issue, we have the solutions? What we need to focus on is funding those and improving the connectedness and access. Instead of is spending an enormous amount of more time on resources on coming up with new innovative solutions and new models of care, are we actually at the point where we just really need to put our money where our mouth is and resource the systems that are actually there in the first place? My second point is that my experience with the forensic system is quite different to Steve's, and I actually see patients that go into the forensic system and their mental health deteriorates incredibly because they are not able to access their ongoing mental health treatment. And then they are discharged into the community with actually absolutely no connection to either acute or community services that are going to be needed to treat them. Do you think that there needs to be statutory change or, I guess, attention given to the mental health acts around Australia to address that issue?
David?
Well, firstly, I think one of the real problems is that we don't actually have great research on solutions for these system type problems. So we've got the system we've designed over the last decade or so, and it's got a lot of pressures coming into it. So we have very good research about what works in mental health, that we have very good treatments for a lot of the diseases that we have. But how we change our systems to make sure that they're not harmful to patients, we don't even know what the long-term harms are. There is no research that I could find on the long-term harms for bringing people through emergency departments, delaying their care and bringing them out. There's short-term stuff, but there's certainly no long-term stuff. So one, we need to actually focus on research. Every time a new program gets put in, any government worth its salt should say you have to spend a certain percentage on evaluation for that program. Proper evaluation, proper outcomes, not just surveys and do we like what's happening. Because otherwise we're not going to find out what works, what doesn't work, what can we change.
Tony?
Look, I just want to take up on Dave's point there. The research and the evaluation is really important, but as Sarah's outlined, we've been talking about this for many, many years. There is things that we can do now in parallel with the further evaluation, in parallel with the vision, the strategy, the leadership that's required. And really, the problem is that in terms of the governments who control the purse strings, the ministers or the various cabinet secretaries or whatever are getting different messages from different people in their ear, and they don't know where to put the really small bucket of money that they do have to spend. They don't know where to put it, and it ends up being the one with the loudest or the most connected or the most convincing argument of something that's still not yet thoroughly potentially either evaluated or whatever. So that's why we need to have a coordinated approach at trying to formulate where the funding goes. But you're right, we can do things now, and that's what we've.
Ian.
Just on the evidence issue, I'd recommend to people that are interested, there's a monograph by the Institute of Medicine in 2007 about quality care in mental health and substance abuse. And there is actually good evidence at a system level what works. It's person-centric, it's collaborative, co-located, organised sets of things, and it's data-rich in terms of actually what is going on within those systems in a continuous improvement type model. Now, of course, the best examples are actually in the US in managed care systems. And you say the word managed care in Australia, everyone goes, no, we prefer chaos. And what we have is chaos. And we say, no, we prefer that. So there's a kind of trade-off here between really do you get organised. Personally, I'm in favour of getting organised at regional and local levels. But there are strong principles behind that. They strongly depend on professional leadership in that. So I commend Tony, and I think the issue is, as well demonstrated here this afternoon, there are many different bits of the medical profession that need to get their act together to argue for it.
Thanks for your question. Microphone 2.
Thanks. I'm Meredith Ward. I'm a neonatologist and paediatrician from Sydney. I work with a substance use team, and we're obviously experiencing the mental health issues both at the child and the parental level. Speaking for my families, I'm fairly clear on what we need. We need trauma-informed multidisciplinary care. We need to have clear access points for referral. If I refer a child with a developmental problem to a developmental centre, the multidisciplinary care is then taken care of from that centre. You'll have dietitians, speech pathologists, physiotherapists, paediatricians involved. My patients, from a psychiatric point of view or mental health point of view, need to have psychologists and psychiatrists and trauma-informed OTs and social workers and drug and alcohol workers, and the list goes on. I'm required to coordinate these referrals, most commonly from myself as a paediatrician with 4 or 5 separate referrals. In the rare cases where I can find a community-based team that can do this, their services are overwhelmed with demand. So first of all, I'd like to ask that you include paediatricians and drug and alcohol workers in your planning. And secondly, that we consider other models of team-based care based in the community and how we can improve the access and availability of mental health services along those models.
So that's what a great question. So Ian, I'll start with you, Ian, but others may. What can we do to try to make it easier for what can we do to make it easier for health professionals to work together?
What an amazing thing. We totally agree with the model.
I know, the model seems simple. This is what I don't understand, is that model does work, and that model works in other areas of health.
So one of the issues is, in a sense, there are other areas. One of the issues is of scale, actually. The other is the professions that actually work in those areas. And then the developmental example you gave, that is the existing model, and to depart from that is seen as less good care. In a lot of other areas, we have this continuous argument between all of the professions involved that actually what they do individually is better. So Sebastian and I do it every week. You see Sebastian's Twitter account getting abused every day of the week whenever he says anything like you just said. We say it is self-evident, not self-evident, there's actually good evidence that the outcomes of those forms of multidisciplinary care are better, particularly against function over time. The trouble is to go to scale with those, to have enough people operating in that way for the volume of demand that actually exists. So both within the public sector, but importantly in terms of organising the expertise that lies in the private sector in Australia, my belief is we need funding models and governance models that support that in the private sector, along with that being the case within our public sector organisations.
Thank you. Thanks for the question. Microphone 1.
Hi, Jazz Sani. I'm a GP working in Western Sydney. Have the pleasure of serving a predominantly paediatric population there, and there are a number of reports that are released in regards to the burden of mental health in Western Sydney. I'd like to move us a bit further upstream to where my patients mostly are, which is the 0 to 5 age group. Ian, I'm glad you mentioned the US example. It gives my question a bit more credibility because I'm talking about the US in a good way right now, and that often isn't perceived as the way the US healthcare system operates. But there are pockets of excellence, as we know. Kaiser Permanente and the Centre for Disease Control do a adverse childhood experience research, and they base the research on the Adverse Childhood Experience International Questionnaire, and they find that 6 or more points on the ACE score equates to a 3,000% increase in attempted suicides, which is phenomenal. I see that as my patients get older and as I start serving them when they're in their teens and later on. The question for me is, at the moment, who owns this problem? Who is funding the solutions? And how do we move forward and include the 0 to 5 age group a bit more?
That is such a great question. Okay, who owns the problem? Nobody. Who's actually doing anything about it? Not anybody. However, there's a major piece of policy change which happened under Malcolm Turnbull, but is now happening overtly and mentioned by the Labor Party in the election last weekend, about the transformation of early childhood care to early childhood education and a focus on developmental issues, the number of kids that reach the developmental milestones in those areas, and the lifetime risk of mental health problems, etc. So as highlighted by the National Mental Health Commission, it remains the biggest area of neglect on an ongoing basis. Lack of sophisticated assessment, lack of available interventions in those particular sets of areas. So I think the solutions are actually seen as happening potentially under the childcare fabric. As the government's put more and more money into childcare, largely around female workforce participation, the opportunity for actually picking up problems early and responding more appropriately to developmental issues. They're not the worst developmental issues, more subtle developmental issues that have lifetime impacts is potentially there. But it requires a whole different way of working with childcare, with families in those early particular years. And one of the issues that's been raised a lot is the unwillingness, in fact, of health professionals to work in partnership with those early childhood environments in effective ways. And in quite individual ways, because the individual needs are also quite large in those areas. So it's an area of desperate need for investment, but again, I'm afraid to say, for professional leadership to respond. We have a lot to offer in those areas to drive how
through families, through childcare, through education, problems may be responded to.
So, sir, I don't know if you've seen also, but the Australian Research Alliance for Children and Youth have also put out a series of papers, monographs and things about 0 to 5 mental wellness, mental health. That's also worth having a look at, but it's just part of the puzzle. We have 5 minutes left. I hope we can get through to everybody. Microphone number 2.
Hi, I'm Jessica Dean. I'm a intensive care trainee and I'm also a director on the board of Beyond Blue. I think a really key opportunity here is in early intervention and prevention. With a program such as The Way Back, which is one of Beyond Blue's programs, which is essentially a post-suicide intervention, the outcome measures are quite easy to find. You know, they've reattempted suicide or completed suicide. But with other interventions, particularly the low-intensity ones, the outcome measures are more difficult to quantify and there's less consistency across the board. The issue that I see that we face is that the PHNs have a lot of control over where the investment is, and they generally have a preference for, well, they're very cost sensitive, and sometimes that comes at the expense of the quality of the service. How do we encourage investment in evidence-based interventions, particularly in the low-intensity space?
Anybody like to answer that?
Well, I don't think it's that difficult. You fund what works and what's got an evidence. And yes, some things are more difficult to measure than others, but there are always outcomes that you're looking for. So whether it's functionality or whether it's attendance, whether it's staying in school, whether it's achieving other outcomes, there are things you should measure that are actually important, not just, did I like the program or did I? But, if you don't fund that way, I don't see any way out of. So, and PHNs in particular, because they're supposed to be funders of, gaps in the area, they have to show that they coordinate properly, that they actually engage people, that they're easy to access and that their services actually deliver, some improvements in their population. And if they're not doing that, I don't understand why we'd keep on funding them.
Can I say that PHNs have to fund the totality of programs too, so funding programs in isolation in any particular area. So we've been encouraging PHNs to look at the modelling for the populations they serve. You can put the wrong program into the wrong population place, or you can select a program or 2 programs and actually leave a whole lot of us out. So the PHNs face a complex issue of modelling for their areas, what is the right choice, and hopefully using better programs as distinct from perhaps pre-existing programs.
But can I just say, this is an absolutely critical moment in terms of leadership, because the markers of what we should be looking for to qualify for investment should be determined by you guys. They shouldn't be determined by people who don't know as much about the services, their intentions and their outcomes. So I think this is a critical place for professional leadership to be exercised. I've got to stop. I've got 1 minute left. There's one more question here to microphone number 1. Yeah. Sorry.
Dr. Sanjeev Bandy is my name. I am the AMAQ Council member for Capricornia. I come from Mackay, which has got the reputation notoriously of having the highest rate of youth suicide in the country, 8.9 times the national average. I'm also a proud community ambassador for Movember. We basically lead the world in raising awareness of mental health and suicide, and it's an Australian organization. 75% of suicides worldwide are men. We lose a man every minute to suicide worldwide. Our program, which calls for talk, which we've listened to today, ask, listen, encourage action, and check-in has been very successful. But based on Treasury data, between 2015 and 2016, Australian government spent $9 billion on mental health and suicide prevention. Based on the budget for this year, 2019-2020, we hope to spend $1.45 billion. How in God's name is that going to fix the problem? Please explain.
Do you want to have a go?
Can I say, suicide prevention is a complex issue. We talk about health system delivery, which is complex enough. Suicide prevention is very complex. And around Australia, if you look at Year 12 completion rates, you look at unemployment rates, you look at other socioeconomic indicators, they are much bigger determinants of suicide rates than a lot of other factors. You know, so suicide in Mackay, suicide, in the Kimberley, suicide in inner city Sydney where I live, there are complex different determinants in different places with different populations. So we need to be part of the solution, but no one program, no one health system initiative will deal with those sets of issues. These are serious community by community issues. The bigger issue in Australia is the regional variation in suicide rates and the socioeconomic, educational, employment and other factors. Social connection, however, matters a lot in those particular areas. So just say, we are lucky all to be part of a profession that is actually very connected. Many other people are not so connected. So I'd encourage people to also be important members of their local community. That connectedness is probably the most important thing that we can actually personally do around suicide prevention.
Tony.
And I think that's a perfect place to end this discussion on, in terms of remembering that we are part of the environment. That environment is very crucial in the prevention, and rather than we're dealing with how to deal with the problem at the end of the line, but it's a much more complex discussion than that, but it's really important to remember and part of the process.
Thanks, Tony. So just to be clear, of the $9 billion that's spent, from what I can find, I don't have a hobby, I spend too much time in AIH, Australian Institute of Health and Welfare, Excel spreadsheets. I think we spend about $50 million on suicide prevention from the federal government, probably another $50 million from the state government. So it's it's $100 million out of $9 billion. Don't leave, because there are some announcements that need to be made, but that is the end of the session. I apologise very much to people who had a question and didn't get a chance to ask it. Can I ask you again to thank this terrific panel for a very stimulating discussion? Thank you. Oh, yeah. Thanks. Thanks very much.
And thank you very much, Seb, for ably chairing that wide-ranging discussion. And, reforming Australia's mental health system, perhaps today is the day that it all starts. We've certainly heard the call for the AMA to take the leadership role in this. Tony, your call, you've got a year to go. You can make something happen here, and we might look back on this meeting in Brisbane in 2019 and think that's when things turned around. Thank you very much to the panel, and that concludes today's sessions. We're off to dinner at 7 p.m. at the Brisbane City Hall. See you there.